My name is Randy Hecht, and I'm a GI oncologist. I run the GI cancer program at UCLA. And what I'd like to talk about today is the OrigAMI-3 trial, and this is our trials in progress here at ASCO 2025. So OrigAMI-3 is a registrational trial. It's a large randomized trial using a drug that's already FDA approved in lung cancer called amivantamab in second-line colorectal cancer. Now, I've been working with anti-EGFRs in colorectal cancer since the early 2000s, and these drugs, such as panitumumab and cetuximab, clearly help patients. Now, the problem is that they only help patients so much. And one of the reasons that is because the duration of response is only so long. So one of the thoughts is that there's specific resistance factors that have been looked at in patients who've been on anti-EGFR, and one of the most important ones is MET. Now, amivantamab is a bispecific that inhibits both EGFR and MET, and has been shown in metastatic non-small cell non-small cell lung cancer to have significant activity and is FDA approved in that setting. MET is also important in non-small cell lung cancer. So therefore, in the early OrigAMI-1 trial, which looked at various patients at various stages of metastatic colon cancer, first line, salvage, there were either alone or in combination with chemotherapy, there were significant responses. And this has led now to two large trials, one of which is called OrigAMI-2, which is a first-line trial, and then the trial that I'm the PI on, the principal investigator on, is called OrigAMI-3 that I'm talking about today. This is a global trial. It is a registrational trial. Patients with second-line colon cancer, at least in the United States, usually get a combination of chemotherapy, which is usually irinotecan-based. Depending on their RAS status, they would either have an anti-EGFR, such as cetuximab, or bevacizumab. The randomization, which is 1-to-1, is the standard chemotherapy with amivantamab. Amivantamab was originally given IV, had more infusion reactions. We know that sub-Q, which is also now used in non-small cell lung cancer, is better tolerated. This is a large global trial, as you can see, in multiple countries. In 26 countries, 700 patients. Primary endpoint in second line, PFS is important by centralized review, but this has a dual endpoint of overall survival. They're the usual secondary endpoints. One of the things that also is important is that at least in first-line metastatic colorectal cancer, a very kind of crude way of dividing them up is called sidedness. And so we talk about right side and left side, and depending on whether the tumor is right-sided, where anti-EGFR antibodies don't seem to work as well, versus left-sided, which is about 2/3 of colorectal cancers, where anti-EGFR seems to work well. The other thing that's the second line, it's unclear, and this actually does not exclude patients based on sidedness. The other really important exclusion criteria is RAS status. So about half of patients with metastatic colon cancer have RAS mutations, usually KRAS, rarely NRAS. About maybe 5+% of patients also with metastatic disease have BRAF mutations. We know that those mutations are they're excellent markers for lack of benefit from anti-EGFR. So therefore, this is in that roughly half of patients who we call wild type. So they have KRAS, NRAS, and BRAF wild type molecular testing. For patients, this is standard and is done in first line, so this is already known. So we're excited about this. I think that there's a clear need in second line where our response rates are relatively low and duration of response is also measured in months and is relatively short. And so therefore, we're excited about doing this trial.